Our keynote speaker today is Dr. Ty Wallis. His experience includes a one-year internship at Oak Ridge Equine Hospital in Edmond, Oklahoma, followed by a 3-year residency and combined master's program in equine surgery and lameness at Colorado State University Veterinary Teaching Hospital in Fort Collins, Colorado. He became a board-certified large animal surgeon in 2009, is a diplomate of the American College of Veterinary Surgeons, has practiced in Tennessee and South Carolina, and ultimately teamed up with Dr. Hill. In 2014, he moved back home to Texas, is currently based in Pilot Point, where he focuses on lameness, sports medicine, pre-purchase exams, and orthopedic surgery of equine athletes in training centers throughout the country. He has also been the surgeon for Michigan Equine Surgical Associates since January 2012. He is a member of numerous organizations, including AVMA, AEEP, and the list goes on. And he is an Arabian Horse Show delegate to the AAEP Performance Horse Task Force. And ladies and gentlemen, without further ado, please welcome our keynote speaker, Dr. Ty Wallis.
Well, I'd like to thank everyone for the opportunity to address you guys with this keynote address today, especially Nancy Harvey, Becky Nash, and Kathy Hart asked me to do that after the luncheon talk that we had last year. And I said I'd be delighted to do that, and asked them what they wanted me to talk about. They said, well, whatever you want. I said, okay, well, how long do I have to talk? Well, as long as you need. So I kind of toyed around with the idea of a slide deck of about 350 of my favorite airplanes. But what I settled on was advances in equine orthopedic therapies. Being that this year's theme is Shape the Future, I thought it might be interesting to kind of look at that from a veterinary perspective and kind of talk about some of the changes in orthopedic techniques available to primarily our athletes. The talk that I gave last year focused more from a breeder's perspective on what we could do orthopedically for younger horses. And in this talk, I want to talk more about what we can offer to our athletic horses. This is an area that's changed a lot. During the introduction, mentioned that I've been practicing for only 15 years. That's not a very long time. But the advances, particularly in this area of veterinary medicine, are pretty remarkable. Just a little bit about us. Showed this slide last year if you're at the talk. We've had a couple of additions. Dr. Bailey Smith in our Michigan location is engaged to Dr. Jay Skelton, who's going to be joining us in our Texas branch. He's finishing up a surgical residency at Purdue. And Megan Sitzman, who's been a youth exhibitor, many of you know, she just accepted an internship with us and will be training with Dr. O'Cole in our California division. Everyone in the practice focuses on lameness and sports medicine. Dr. Bush and Dr. Walker in our Texas location, because that's the only place we have an actual clinic. The rest of it's 100% ambulatory. They also have a routine practice with emergency and regular care. Our practice is largely focused on Arabians, probably greater than 90% if you add it all together. We attend about 35 Arabian shows per year. We're glad to be the official veterinarian at all the national events and multiple regional shows. And our practice consults with farms and trainers across about 25 states, and that list seems to grow. I'm definitely glad I didn't have to follow Mary's video. I'm certainly more of a crier than Bob Nash, who she called out and is my neighbor. But we are so fortunate to be involved with an organization such as this one that cares so much about taking care of each other. And these are a few of the organizations that we like to support. And I encourage everyone else to do the same, because it sure makes a difference. So moving on to the meat and potatoes here, I kind of want to talk about 3 areas of advancement in equine orthopedics. The first one would be implant design of the implants that we use primarily in fracture repair. Those have come a long way. The buzzword is regenerative medicine. Many of those are biologic agents actually coming from the horse, going back into the horse. And those are constantly evolving and new ones are coming out. And then there's a new line of regenerative equipment, which many of you are familiar with, but one is quite new, and so I want to discuss a little bit more about what it does. So put this slide in here because my dad, when I was growing up, he always had one of these Far Side calendars sitting on his desk. He's an electrical contractor, and it had a cartoon on it and the date, and he'd peel that off every day. So when I got my surgery residency at CSU, I got, you guys remember snail mail, where you actually get an envelope in the mail? So he had a folded up cartoon in there, and I pulled it out, and it happened to be this one, and so I've saved it. And it's humorous, but it's a bit of a dire look at what most people view as particularly orthopedic medicine in an equine hospital, where there's just not a lot that can be done in these severe traumatic cases. And that was the reality. We grew up having a few horses, and you know, if you ever heard about a horse fracturing a leg, that pretty much was the only treatment available. Well, if you fast forward just a few years, all the photos on the right are of Barbaro, which is a case that we're all familiar with probably. And look how much has changed. So we've got a severely traumatic fracture. This is a lateral condylar fracture of his hind cannon bone. He's disrupted a lateral suspensory branch apparatus. These sesamoids are no longer level. A severely comminuted fracture of P1. And prior to this little plate right here in the front, there would have not even been a consideration about trying to repair this fracture. And even though this had a kind of a heart-wrenching outcome, I'm kind of presenting it here more as a success, and the reason is this construct did not fail on that horse. And this is the most impressive photo to me. You can see this is immediately after repair. There's the bone's not even touching, and yet this whole construct survived infection. And he ultimately, you know, we lost him to laminitis in the other limb. But this is Dr. Dean Richardson at the New Bolton Center at Penn, internationally regarded as the best orthopedic surgeon. And there's some kind of cool things going on in this photo, right? So he's recovering this horse. This is Barbaro. This is a pool recovery system that they have at Penn, where their horses are placed in a sling on the surgery table and hoisted overhead. This little device is floating in a swimming pool, and it's got 4 rubber legs in it. So their legs are protected from the water, and then there's a floating mat that their head's on. So as they start to wake up, you know, that's often a fairly violent event because they don't know what's going on, and horses are fight or flight animals. So a lot of orthopedic failures actually happen in the recovery room. Probably more than half of them do. And so this technology allows that to happen with the resistance of water in a non-weight-bearing fashion, so that those recoveries go a little bit better. And this is him coming out of it. You can see he's awake, and they're pulling him back up. And so he never had to go through that phase of getting up on his own. So, you know, now my dad has an iPhone connected to a little gizmo that projects the date on the ceiling. So when he wakes up, he's got the date. And if he wanted to send me a cartoon, he'd just email it to me. And that's the same thing that's happened on the other side of that slide, just a lot of advances. So I thought we'd kind of go back and look at what that is. So this is the first plate design. These are just round holes, a piece of stainless steel. And all that could do was protect the bone. There's a tremendous amount of force. If you think about horses weigh, just call it 1,000 pounds on average. And a lot of these bones that we're dealing with have a cross-sectional area of less than 2 square inches. That's a tremendous amount of bending and torsional forces. So What makes these successful is the interdigitation of our fracture fragments going back together under pressure. So you have to put some pressure on those so they'll hold. And originally all we had was lag screws. And so here in this cartoon, they've lagged it back together and then are protecting that with just a plate, but we don't really have very strong interfragmentary compression to hold that stuff. And the other problem with this design is we've got a large surface area of metal pressed down onto the bone, and a lot of the blood supply, it's not as big of a deal in horses. Horses, only about the outer third of the cortex of the bone gets its blood supply from the outside of the covering, which is called the periosteum, and the rest comes from the marrow cavity. But in small animals and people, that equation's reversed. So it was a lot bigger deal to not have quite so much pressure. So first thing they tried to solve was the interfragmentary compression, and they did this with the design of these screw holes. So instead of just being straight, they're sloped on one side. And you can drill your hole non-eccentrically towards the edge, and then as that screw goes down, that head of the screw kind of hits that like a ball running down a slide. And that's going to cause that plate to shift, and you can get compression across that fracture. And so you can do that one side on each, one screw per side of the fracture. Then you can actually drill these holes eccentrically as well, back those screws out a little bit, and do two more. And so you can actually end up with about 4 millimeters of compression across the fracture line, and that's a big deal at holding that bone back together. But we still haven't solved the contact issue. So then they came out with this called the limited contact dynamic compression plate. So it still has those sloped holes to allow compression, but they've also taken the underside of it and scalloped it out, as you can see on this photo on the right. And like I said, that's a big deal for less contact area for small animals and people. All the plates are the same, they're just different sizes, but it's one company essentially that makes all of them. So not as big of a deal. We don't tend to get as much osteoporosis under the plate, things like that. But a huge deal for us are the stress risers of these holes. So we can't usually put these plates on straight. We have to bend them a little bit to make them follow the contour of the bone. And those plates want to bend right at the holes, which number one may not be where you want to bend it, but number two, once we get it on the horse and the horse's bone is trying to bend, that's a weak spot, and a lot of these plate designs ended up failing at the holes prior to this. But what this picture on the bottom left is depicting not only the decreased contact area, but also no matter where you cut that plate, the total cross-sectional area is the same, the way they designed it. So you can bend it wherever you want, there's no stress riser effect. You've probably had a friend in a car accident or maybe a small animal that you've seen with one of these external skeletal fixators on. And we don't have an opportunity to use these very often in horses. Sometimes we'll do it on their jaw. But where they're useful is if you have an area where there's such trauma that you can't put an implant there, or if you have infection, then you actually move the strength of the implant outside the animal. And what really makes that strong is this fixed angle. This is a little locking mechanism that keeps that angle fixed between each of these pins and the external pin. And so some smart engineer in Switzerland came up with the idea of taking that technology to a bone plate where that could be applied underneath the skin. So in a traditional plate, all of the stability of the whole construct comes from that screw pushing that plate against the bone, and the friction that's created there between that pressure is really all that you have holding it together. But as the horse's leg, these bones, you can't imagine how much bending force they undergo at the micro level. But through thousands of cycles, that plate wants to cycle back and forth, and that screw is allowing it to do that, and eventually that screw just wants to back right out. Well, with this technology, we solve both of those. The head of the screw is actually threaded, and you can see what these holes look like. This is called a DCU hole, where we have opportunity to use either type of screw in there, but it's threaded on one half and then has the compression slide on the other half. That keeps that screw at a fixed angle no matter what, and also because it's threaded to the plate, this all becomes one unit, so the screw came back out. And these are just a few more cartoons to kind of better illustrate what I'm talking about. So with your traditional plate, it truly is a race between healing, infection, and implant failure. And if you could beat infection and get the body to heal prior to one of these events happening, then it was a success case. But more times than not, we had screw pullout or plate breaking or something like that. You can see that the way this is designed, because that screw can rock back and forth in there, those can all just strip right out. But in this model, where that's a fixed angle, the only way this can fail is if all those screws break or all of that bone breaks. So that just makes it a lot stronger. But again, with that combi hole, we can still use the other type of screw. So you can see this screw has been over drilled through this fragment of bone. These threads aren't catching anything. It's only threaded on this end. So that allows us to attach the plate and also compress across that fracture. And this is the kind of more the same, just said in a slightly different manner, that, you know, this plate doesn't technically even have to be on the bone. It's acting more like that external skeletal fixator outside of the dog's leg from a few slides back. But that allows all of that shear force to be transferred against the screws instead of going on one particular screw. So on to something maybe a little bit more interesting. Sorry for all that technical stuff, but number one, I think it's really cool, but number two, here's how it impacts us in the real world. So I was at a farm preparing some horses for Youth Nationals, got a phone call from Dr. Bush, who was at one of our breeding farms, and said, I've got a horse with a dropped elbow. You can see obviously we're non-weight bearing on the leg. We've got the hoof turned towards us, dropped elbow, no tension on the leg. That can only be one of a few things, either nerve paralysis, which wouldn't give you a turned out foot, a fractured olecranon, or a fractured radius. So she radiographed it, and sure enough, we've got a complete radial and ulnar fracture. In the horse, the ulna provides a lot of support up at the elbow, and that's where the triceps hooks on, but it's a vestigial bone down here, so they don't really have two substantial bones. So if you get a mid-diaphyseal radial fracture, you always have an ulnar fracture because you can see how thin it is. There's really nothing involved there. But this is a rather lucky fracture. It's a mid-diaphyseal. This is the diaphysis of the bone. It's a long oblique fracture, which gives us a lot of contact, so we can get a lot of interdigitation and interfragmentary compression between those two spots when we go to try to fix this thing. So we discussed options with the owner, and she was willing and able to try saving the horse. I'll admit I gave it a pretty poor prognosis just for all the reasons that we've described before. It's very difficult to get a fracture like this to heal. It's a 3.5-month-old horse, probably weighed 375, 400 pounds, something like that. So that was working in our favor as well. These are radiographs taken with the horse on the table. So I've turned them upside down so all these images match with up is up and down is down. But in reality, the horse is laying on his back with his foot tied to a hoist overhead, putting that leg under some pretty strong traction, trying to beat the contractile forces of the muscles that are wanting to separate those fragments back out. And you can see just by doing that and letting the leg relax for about 10-15 minutes, we're starting to get things lined up in both planes. So after making the incision and the approach, exposing the bone, we put these large fractured forceps on here to kind of compress things down a little further, make sure we like the alignment, and then place a couple of just little lag screws. I think I'm losing battery on our pointer here. A couple of lag screws just to hold things where they belong so that we can start working with that plate that we've been talking about. So here's the plate as it comes. You know, you can tell that we need to do some contouring of it to make it fit the front of the bone. That's been accomplished in this step, and we're just holding it on and checking it radiographically to make sure we like the placement and where it stands. And then this is with all the screws applied in that particular plate. So this is on the front of the leg, screws oriented in a front to back fashion. We've got a combination of traditional screws across here to get that compression, and then all the ones that are at a right angle that are a little bit less thread that you can see, those are all the locking screws. So we got that one on. We started this project at about 11 p.m., got that front plate on about 3 in the morning, and my anesthesiologist was breathing a sigh of relief and pretty troubled to hear that I had one more plate to go. So then we put this plate on the lateral side to give us strength from a 90-degree perspective, and this is just 2 radiographs of the completed construct. This slide here, just sort of explaining what that looked like. So it's a fairly long incision from that horse's knee almost up to his elbow, and then because there's so much musculature on the front of the leg, to get that lateral plate on, I had to make another incision for some of the screws up proximally, just because I couldn't get everything moved over to get a screwdriver in. This is about 2.5 weeks when we took all the staples and sutures out. This horse healed quite well. This is a video that I took the day that we took the sutures out, just him in a stall. And it's that left leg that's affected. You can see he's using it pretty well. He's got a little bit of laxity. It kind of wants to bend back a little bit, but overall, pretty remarkable. These are our 4-month films. One on the left is shot from front to back. Had to take 2 x-rays to get the whole implant on there, so that's why that's stitched together that way. But you can see the fracture line is gone. We've got constant cortical bone running up both sides. One big thing repairing these in youngsters is this is a growth plate in his proximal radius. And this is the ulna that we were talking about, where all those triceps muscles hook on. And this right here is the elbow joint, and you can see that's made up of 3 bones. We got our humerus, radius, and ulna. Had to have a screw across that growth plate, which is going to arrest growth of that bone a little bit. So we kept checking that to see if we needed to get that screw out. I needed it for strength, but we wanted to make sure that we didn't get disparate growth here with a big notch where the elbow would start to develop arthritis. But we got lucky because of this situation, but with the ulnar fracture actually healed to the radius as well, so it couldn't grow. So they both grew at the same rate, so didn't end up with any OA. Trainer took this video just this week. That's him jogging around at 20 months of age. Another application of that same technology that's commonly used in our industry is for quote-unquote high ring bone. That's severe arthritis of their pastern joint. This particular horse was referred in. He was lame at the walk. Grade 4 out of 5 means you can see a lameness at the walk. And the goal was to return to athleticism. He's a fairly young stallion, shows in the English Pleasure Division. These are his preoperative radiographs from before surgery. This is the joint we're talking about. You can see all this bone being deposited around the sides, and basically minimal joint space down the inside and toward the front of the joint. We had bone-on-bone contact, and that's uncomfortable. This horse was treated with some initially corticosteroids and later more regenerative medicine, IRAP, and it just got to the point where it wasn't working. And so we went in and used that same technology. You open the joint up, get rid of all of the cartilage so the bone can actually touch and heal together. And then we've got a locking compression plate on the front with 2 locking screws and 1 regular screw, and then 2 big 5.5 screws providing compression down the back. So with this construct, we have compression in the front, compression in the back. It's extremely strong. I had to shift everything over on him because he actually had a fracture of distal P1 that came off when we were doing plate contouring. So we had to kind of move everything over. But this horse has done remarkably well. I usually tell people 9 to 12 months before they're even back to athleticism at all. But this one healed well, and he was sound, returned to training at about 6 months, and then he actually showed successfully at 9 months at U.S. Nationals this year. Moving on to some of the regenerative biologics, I feel like this is something a lot of people use and talk about, and if you haven't ever been there while it's happening, you might not quite understand how the process goes and what the differences are, particularly between IRAP and PRP. So I just wanted to run through those quick. IRAP stands for interleukin-1 receptor antagonist protein, and so that's a mouthful, so that's why we call it IRAP. But basically, interleukin-1, you can just think of him as the bad guy in the joint. So if we have any sort of injury to the cartilage in the joint, the lining of the joint capsule produces interleukin-1. It sits on a receptor on the cartilage and causes all kinds of bad things to happen. The cells start dying off, inflammatory proteins are produced, and we start losing cartilage and developing, ultimately, OA, osteoarthritis. So this is just a little video that kind of describes how we collect IRAP and what it is. So we sterilely prepare their jugular vein, pull back 60 cc's of blood, and the kit comes with this little plastic tube that's got glass beads in it. That's a proprietary substance coating those beads, so nobody knows except the company exactly what they are. Most people suspect it's a compound called chromium sulfate. But basically what it does is it stimulates a cell in their blood called the monocyte to produce extra protein. And so we take that, we incubate it for about 16 hours at body temperature. This graphic is just depicting those monocytes binding to the bead and creating more of the IRAP protein. There's probably a lot more than just IRAP that gets amplified in this process, and nobody has done the work to find out what all of those cytokines are. But for sure, the biggest one is the IRAP. So then we spin it down in a centrifuge. That separates those red blood cells down with the glass beads, and you draw it out through a millipore filter. So this filter right here takes any bacteria out that might have happened to be in their bloodstream that could have been amplified through that incubation process. And then we pull it off in 2 to 4 mil aliquots, depending on what joint we plan to treat. And then you can keep that in the freezer for up to a year. And so then we come back and inject that into the joint. So it's the horse's own protein. It's a completely natural substance. And that IRAP goes in and sits on the receptor. And basically, it's like setting a pick in basketball. It keeps the interleukin-1 from ever attaching to that receptor, so it can't ever have its effect. And these graphics just kind of depict that a little bit. So here's the red one would be the interleukin-1 attaching to the receptor, but we've made all this IRAP and put it back in there, and so now the yellow IRAP is attached to the receptor. So interleukin-1 is still produced, it just doesn't ever have its action because it can't hit that receptor. PRP, on the other hand, is platelet-rich plasma. Platelets are always the first guys on the scene when something goes wrong. So if there's a cut or any sort of trauma, platelets show up, they start the initial clotting process, and then they produce all of these factors, which I'm not going to read off to you, but I just put the list up there to let you know that there's a bunch of them, and they've all been studied individually. And when we make platelet-rich plasma, we're amplifying that effect because we take the platelets out of a certain amount of blood, spin it down, and resuspend it in a smaller volume, so you've really concentrated those effects. There's a lot of different ways to make PRP. There's gravity-fed systems that you can do stall side all the way up to, this is what we use in our practice. It's kind of the state-of-the-art, completely computerized, where you can choose the exact concentration of PRP that you make as far as how many times you've amplified the platelets. You can have it put white blood cells in or not put white blood cells in, depending if you're putting it in a joint or putting it in a tendon. There's research showing that with or without may be better for a particular application. But basically, this is all sterile. The kit comes all sterile, and you place it on the machine. You can pull anywhere from 60 to 180 mils of blood from the horse. It ends up going into that bag, which was the step that we were at when I accidentally hit that. And this little gizmo pulls the blood out of that bag and into the large cassette and then spins it. And it spins it at a variety of different speeds from 17 to 2200 RPM until it separates those platelets out. And then once it's gone through enough time that it knows it's only going to be getting plasma, it starts pulling them backwards. So here's the blood being loaded into the cassette while it spins. And then it pulls it back out that same system backwards. And that little blue light right there are 3 different sensors that can tell when platelets are going through based on how much they impede the light. And it sticks your PRP right back into that little syringe. It's all totally sterile. You can transfer that to different syringes. You can adjust the concentration. You can freeze it like the IRAP. If we have extra, we can save it for up to a year and use it again on that same horse. So it's a pretty neat product. Stem cells, everyone's familiar with. They spend a lot of time in the media. On the equine side, most of the focus has been on where we get those stem cells from. Originally, they came out of fat, so we would pull them from the fat around the tail head, send it off to a company. They would extract the stem cells and mail them back. Then bone marrow-derived culture expanded cells got popular, where you would harvest bone marrow either from their hip or their sternum, send it to a company. They would pull out the stem cells and then put them in a culture and let them reproduce until you got really high numbers. We would get those back with 20 to 30 million cells. At the time, all the benchtop research was taking those cells and putting them through different assays where they would expose them to different proteins that might be there in an injury. So certain proteins get released in a fracture. So they would take those cells and expose them to those proteins and see what they turned into. And there was a big push because those bone marrow-derived cells, they had a lot easier time turning into cartilage or bone, and the fat turned into tendon better. And that's how we understood it at the time, is we were putting a stem cell into an injured area, letting it turn into that tissue and repair it. Then someone came along and actually put some little markers on these cells that you could see with a fluorescent microscope and injected them into injuries and then studied those with that microscope to see when they, how long they stayed around. And they're actually only there about 18 hours. And then the stem cells are totally gone. So that kind of allowed us to learn that there's a pretty elaborate symphony going on inside that injury, and the stem cells are just the conductor. So they're telling the proteins what to do, and then they leave. So then all these tissue-banked allogenic cells started hitting the market, which for a veterinarian like me, about 65% of my work's not even in my home state. So I'll go to a farm, look at a horse, diagnose an injury. If we want to treat it with stem cells, then we had to harvest the marrow, send it off, expand it. They would come back 3 weeks later. I had to get a flight back in 3 weeks. And now that we've got these tissue bank cells, we can carry them on the freezer on our truck or have them overnighted, either one. We happen to use this brand right here, VetGraft Pulp Site, which is an interesting product. These are foals that have passed away for whatever reason, and they split their mandible and pull the unerupted teeth out. And so those teeth have never been exposed to any antigen whatsoever. They are completely non-inflammatory, non-reactive to the horse, and they split those and take the pulp out. It looks like a clove of garlic, and those have a very rich source of stem cells in them. And they just come back suspended. We can get them in a 10 million or 20 million dose. They come suspended in a sterile buffer solution, and we can inject them right in at the farm. The newest one that's showing the most promise are these Amnion products. And again, you'll recognize some of these proteins as the same ones in PRP, and they are. It's almost identical protein profile. We also have the actual collagen from the amniotic membrane itself, so we're putting some structure in there that it acts as a scaffolding for new growth. But the way the company makes this, they're based in Phoenix. They're contracted with Oak Ridge Equine, where I did my internship. And there's mares that are going there for elective cesarean section. That's become a popular real thing for mares that have problem births. So they're harvested at the time of C-section completely sterilely. They type match the amniotic membrane with amniotic fluid from that same mare, send it to the lab in Phoenix. They basically snap freeze it at minus 80 Celsius and put it in a thing that looks like a tiny blender. Macerates all that amnion up, and then they resuspend it in the amniotic fluid and send it at minus 80. So we have to have a special freezer on our truck that can keep it at minus 80 Celsius. But it's showing a tremendous amount of promise, and that's the case that I wanted to present for this segment. So this is a 12-year-old half-Arab English mare. Unfortunately, had a very large lesion show up the night before her final at U.S. Nationals last year. This is the medial suspensory branch that we're looking at here, and this whole area, so it was about 40% of the cross-sectional area was just completely disrupted. We injected that with Renovo, And this is actually a 45-day ultrasound, which if you're not used to looking at these, that'll make an equine veterinarian do a cartwheel. We're used to seeing that at about 4 or 5 months. So to see it at a month and a half was just astounding. And this was day 140, completely sound, by the way, back at day 45, and ready to return to work at less than 5 months. And the reason that's cool is because earlier return to exercise is really key to making that strong and not re-injure. So we've learned that as soon as they're comfortable and we actually have some fibers in here, the body lays those down on a crisscross fashion, and we need them to be lined up like strands of a rope to make it strong. And only way to do that is to have tension and force running down that ligament. And so the earlier we can do that, the stronger the repair is, and the less likely it is that we end up with a re-injury down the road. And then finally, just briefly want to move on to the equipment side of things. I just going to talk about the 3 that we use routinely in our practice: extracorporeal shockwave therapy, meaning the shockwave is generated outside the body; therapeutic ultrasound, which is a similar effect to shockwave, but a little bit different application; and then this big one is this regenerative laser therapy. So shockwave, you've probably, if you've ever been to a horse show, you've heard that sound some point in the barn. It's actually created by a little gadget that looks like a spark plug inside the machine, and then it creates a shockwave as a sound wave. It travels through the fluid medium of that little probe and into the body. And it has all kinds of effects. These are a few. It helps the cells grow faster. We get new blood vessels growing in. The hemoglobin's able to carry more oxygen. That actual energy being released helps release those growth factors that we talked about from the platelets that are on the scene. And then it also provides some pretty effective pain relief. It actually downregulates the nociceptor, which is the particular type of nerve that tells an animal that there's pain present. So that shock wave kind of quiets that down. So it really helps with discomfort and sore backs, et cetera. Therapeutic ultrasound is a little bit different than diagnostic. Diagnostic ultrasound are really high frequency waves that give us those pictures that we saw of the suspensory branch a few pages back. These are low frequency. They're much too low to give us any kind of an image. But as they travel through the body, they can create heat. They can have those same acoustic effects as the shock waves do, plus the mechanical vibration of the ultrasound causes all those same effects that we saw on the last page. It's a little bit slower to react than the shock wave, and it takes a longer treatment, but it's not painful at all. I've had this done on me. That's how our practice became interested in it first, is I've had to have back surgery, and it was extremely effective on my muscle pain associated with that. And we find the same thing in the horses. It's very effective at pushing fluid out of tissues if they get edema, and it helps a lot with pain. The regenerative laser is pretty new on the market. We've had ours for, I guess, going on 3 years. Laser therapy is really widely used, and I guess the first thing I want to say about lasers is they all work. So there's class 1 through class 4, and that relates to how much damage you could do with them potentially. Like class 4 lasers have a lot of energy. They can actually be used in a surgical application. Class 3s are kind of the strongest ones without going to that level and on down the road. And when we first got interested in lasers in our practice, we had just some little handheld LED lasers, and they were really effective at pain relief. And so everything on the therapeutic side, on the blue square on that side of the screen, any laser can accomplish that. The strength of the laser, the wavelength, and all that is going to affect how quickly it can accomplish it. But it doesn't matter if you spend $200 on a laser or $65,000 on a laser. They're all going to have that effect. It's just faster or slower. So it really helps with circulation. It pushes the painful mediators and chemicals around an injury out of the area. It, again, helps that hemoglobin carry more oxygen. And then the big thing is it stimulates something called the mitochondria, which is in each cell. That's the kind of the power plant of every cell, and it produces these little energy packets called ATP, and it can more than double the production of ATP in a cell. And so that really helps. Once the body's gone through the pro-inflammatory stage and starts to heal, then we're just speeding that up. What the regenerative laser adds to the equation is this stuff here on the right. That has to be a particular wavelength of laser. This Smart RLT is the one that we have. There are a couple on the market that have this. It's an ND YAG source. It's a particular wavelength. It happens to be 1064. And I sort of always describe that to clients as the opera singer in the wine glass. So that wavelength of that particular source of laser happens to actually stimulate the extracellular matrix, which is the kind of gradu around all the cells, to vibrate at a certain frequency that's only healthy for good cells. So any scar tissue that's already present is not going to survive that vibration, and it's ultimately going to get chewed up by the body and spit out. But that vibration is good for what's called the fibroblast, so it goes in there and creates new fibers. And if you use this on a regular basis between 30 and 60 days, you can actually get fiber regeneration, which we've never gotten prior to this without either a lot of luck or a lot of time. And so this is a case that we used just the laser on, a half-Arab Western pleasure mare, sometime in August, showed up with some swelling on a hind leg. This is an ultrasound of that mare's superficial digital flexor tendon. You can see this big black spot in it. That's a core lesion of that tendon. It was swollen. It was painful to palpation. She was mildly lame, maybe a grade 1 out of 5. Got her to the clinic, lasered it every day for about 40 days. This is that ultrasound on the day of discharge. That lesion is almost completely filled in, all of the swelling. So this is skin to tendon, skin to tendon. We've decreased our swelling outside the tendon. We filled in with some fibers. And again, because of the time of year, that mare was actually able to go on and show successfully. And that was 2 years ago, and that has not flared back up. So just a few take-home messages. This is, like I said, an area that's changed a lot just in my career. It's continuing to evolve on a daily basis. These techniques, I think the big thing is they've saved a lot of horses, but financially they've saved a lot of loss of revenue, loss of use. That is the biggest loss of revenue in athletic horses across the board. It's not colic, laminitis, anything like that. It's actually lameness. So that's important, and I think it's important to realize that none of these exist in a vacuum. So in a real world, we're usually combining one or more of these therapies together, both at the clinic initially and then following up as the horse returns to competition. We continue to use some of these modalities to allow them to be comfortable and do their job for us. So this is Hattie. That's my 7-year-old daughter. And her best buddy Graydon on summer vacation. I thought it was cold this morning, so we needed something to look at that was a little bit warmer. But that's what I've got for you this morning. If anybody has any questions, I'd be glad to try to answer them for you. If not, I appreciate the opportunity.